So please give a warm welcome to Dr. Bogart and to Dr. Mutchler. Thank you.
Thank you so much, Wen, and thank you for inviting us here. We're very excited about presenting to the PPC, and we appreciate CHIPS for helping organize it.
Hey, thanks a lot. I wanted to just start out by talking about our great collaboration in this study and the partnerships, as you can see from the slide. This is a collaboration between APLA and Cal State Dominguez Hills and RAND, where I used to be, which is why I'm still working with the LA communities, and also Harvard, where I am now. And also this study started out actually with Drew and Spectrum, and we're still working and collaborating with them on this and talking with them about the results as well. So first I wanted to just start with a personal story about myself, just because many of you don't know me, may not know why did I get into this field and why did I start studying things like this. And I wanted to just start with a short personal story about a man I very briefly knew named Henry Gordon. And he unknowingly had a very large impact on my life. I met him in 1993 when I was a very young graduate student just starting out. And I met him in 1993 at the LGBT March on Washington. I went to the march with my boyfriend at the time, and we went to support him and my boyfriend and his two gay uncles. And basically, one of his gay uncles was Henry Gordon, who had HIV. And a few months after the march, he actually died over Thanksgiving. And we spent the last days of his life with him in intensive care over Thanksgiving and over the holiday. And then went to his funeral. And at the funeral, his mother came up to me as soon as I got there. And I was surprised because I didn't know her that well. I didn't know him that well. She came right up to me in her grief, and she said, "Thank you for hugging Henry at the march." And at the time, I was really young and naive, and I didn't really realize why she was saying this to me. And I looked at her in confusion. And she said, really, most people he knows don't hug him, and they're afraid of him. And so that really made such an impact, and it was so heartbreaking to me that I really wanted to study HIV and stigma and people's social networks, and how people's social networks can be both supportive and stigmatizing at the same time, and the people that we surround ourselves with can also sometimes hurt us. So that's one of the reasons why we're presenting on this today and why we did this study. Okay. So I wanted to start out basically with the bottom line of the study and what we learned, and then we're going to tell you how we got there. So you kind of have a framework for how we should start and where we're going. So the bottom line punchline of this study really is that people's social networks may affect their HIV treatment behaviors, including whether a person is on treatment or not, and whether they go to the doctor and adhere to medications. So the people we surround ourselves are very powerful. We may not see them all the time, they may not always be present, but they're always influencing us. And what also we found is that certain kinds of social networks and people we surround ourselves with can be very helpful and supportive. And that's why a lot of times we surround ourselves with them. So what we found is if people in your network are also positive and on treatment, you're also more likely to be on treatments and to be attending appointments. And also if you have really strong connections with people in your network and they also have strong connections with each other, that also is very good for your own health. But we also found a number of different kinds of social networks can be harmful, including networks that have more drug partners, people you've used drugs with or that you're currently using drugs with. And that's actually regardless of whether you, the amount of drugs that you currently use yourself. It's really about what the people in your network are doing and how that's influencing your attitudes and behaviors around your health. And we also found that, not surprisingly, if there are people in your network who are stigmatizing, that can be harmful to you as well. And the last point, actually, we have one more result that's not on this slide, but I just wanted to mention because it's hot off the press and we're excited to look at it further, but we're not going to talk much about it today. But we did also find that if there are people in your network who are important to you, who are also spreading misinformation about HIV, you're less likely to be adherent to treatment. So these are all findings that we're going to talk now in depth with you about, but I wanted to mention them because I want you to, I really want to have a good discussion with you and know what everybody here thinks about them and what we can do from here. So just to go into a bit of background, I'm sure many of you have seen this slide on the cascade of care, so I'm not going to go into it in detail. But the reason why I'm showing it is as a starting point, show that many people have seen the cascade and talk about the cascade, but don't always break it down by race, ethnicity, like this slide does. And this is the cascade of care in the United States, and this is a CDC slide, the official statistics from the US. And it shows on every measure of the cascade that African Americans have lower percentages than Latinos and whites. So just looking at this and seeing that's a starting point of our study and why we did a study to look at people across the cascade of care. And now Matt is actually going to talk for a little bit about a few slides.
All right. I'm super tall, so I have to put this up a little bit so you guys can hear me. We're going to kind of back up a little bit and just review what led us to the study in terms of the literature. We knew from the literature that social networks matter for lots of health behaviors. Who's in your network, the people that you regularly interact with, they can make a difference and have an impact on your health behaviors. As you can see from this slide, we put some diagrams of examples of social networks up there. These are all the dots represent people in the participants' network, but they don't have the participant in there, just the people in the network. And with these three examples, everybody's connected to somebody through the lines that connect the dots. Those show the connections between the people. We're going to have other examples that we'll be explaining in more detail, but we wanted to give you some sense of what these diagrams look like, and also the concept of studying a network, where we would really ask a participant about the people in their network. And each person we referred to as an alter, because that's just part of the social networks literature. So, next slide. So one of the questions we were interested in exploring further in terms of HIV and AIDS was how might a social network affect your health? We know that networks affect other things like sexual risk, substance use, even things like diabetes and other health factors. And we know that the networks, the people that you interact with, can shape your beliefs, your perception of norms, your beliefs and norms, and also your behaviors. But there wasn't much research out there looking at social networks in terms of HIV and AIDS specifically, and that's why we wanted to do this study. So what are some of the characteristics that might be important? What are some of the characteristics in a network that we really might want to look at carefully when we're trying to address stigma and HIV? Well, we saw in the literature that it matters the kinds of people that are in your network. So it could be friends or family, or it could be people working at social service agencies, or other people living with HIV. It also matters in terms of the health behaviors of those people. So in other words, what are the people in your networks doing? Are they smoking cigarettes, for example? If they're smoking cigarettes, then you may be more likely to be doing that as well. And what are their beliefs? So in the case of this study, bringing it back to HIV and AIDS a little bit more, it might matter whether people in your networks hold beliefs that are stigmatizing about HIV or sexuality or sex. That might actually have an influence on your own behaviors. So those are some of the things that kind of informed our initial research questions. And we're going to kind of pass the baton back and forth in the presentation to keep it interesting.
So now we're going to talk about the specifics of the study, which was called Project MedNet, and a study of social networks of African Americans living with HIV, both men and women. And this study, as I mentioned, was done in collaboration with academic and community institutions. And also, it was started, we did a small pilot study first at Drew Spectrum in collaboration with Dr. Frank Galvan, who then moved to Vienna Star. And so it's had a long history. And we also have made sure to work with people in the community to see what should this study be about, from the design and till now to the dissemination of the results, and talking with people about what should the next steps be. So we've worked with the APLA Community Advisory Board, and we've worked a lot with Drew and Spectrum in presenting results along the way. So the overall research question of this research is, how are social network characteristics associated with HIV treatment behaviors across the HIV cascade? So we really wanted to follow people across a one-year period in their lives and see how do their social relationships, their social networks change, and how does that in tandem change with the health behaviors and their health outcomes. So including engagement and retention in care, antiretroviral treatment adherence, and antiretroviral treatment use. So the data collection was, we collected data from 242 African American adults living with HIV in Los Angeles. And what we wanted to do is get at people who are both engaged in care and going to care regularly, but people also who are not engaged in care, who hadn't seen a doctor in a while. We also wanted to find people who are adherent and non-adherent, and people who are virally suppressed and not. So we wanted to get the full range of individuals so we could really study social networks more comprehensively. And so what that meant is we had to do a lot of different recruitment techniques, and I'm saying we, but Sean Lawrence, who's about to talk to you and do some slides, so did a lot of it, and he can talk to you more about that. But so being on the ground and really trying to get the word out everywhere. And this meant flyers at social service agencies, working closely with clinics as well, such as Oasis. It also meant that we wanted to go out into local media, because people who aren't engaged, as we know, may not be going to social service agencies or clinics. So we had bus ads, with metro ads, radio ads, where we said things like, are you not going to a doctor but have HIV? So we tried to get people who weren't going to care. We also went to transportation lines, food banks, places where people might go but who don't have to access healthcare at the same time, so that we can find a true range of people. And for the surveys, we used audio computer-assisted interviews so that they could take the computer on the laptop and in private if they wished. So to measure health behaviors, we used a combination of self-report and other techniques. So for antiretroviral treatment use, we just asked them, are you taking antiretroviral medications for your HIV? But if they were taking them, they were actually required to bring the bottles with them and the medication bottles with them, and we could verify that. We also looked at care retention and asked, in the last 6 months, how many times did you receive HIV care at a clinic or from a medical provider? We also actually got medical records data on this that we're still in the process of analyzing and validating this question with and making sure it's accurate. And finally, for antiretroviral treatment adherence, we electronically monitored the adherence daily. So everybody who was in the study for 1 year, we monitored adherence daily over a period of 1 year, where they had an electronic CAP, a medication events monitoring system, or MEMS, and basically a CAP with a computer chip that every time they opened it, we would record an opening, and we could link that up with the prescription and how many times we knew they were supposed to open the bottle in a day. And every time they came in, we could download the data and actually look at their adherence in real time. So next, Sean Lawrence is going to talk, and I mentioned him. He's going to tell you a bit about how we actually assess social networks and talk to the participants. Thanks.
Good afternoon, ladies and gentlemen. I guess I'm the middle road of the height situation. Once again, my name is Sean Lawrence, and I'm briefly going to describe how we gather the participants' social network. So we use a system called EagleWeb to basically gather this information. We would ask the participants to name 20 people, or as we called alters, with whom they've had contact with in the past year. And by contact, basically we meant anyone they saw in person, they talked to over the phone, if they wrote a regular mail or email. And then after that, we would ask the participants to break it down by social demographic information. So we would ask the participant to name the alter's gender, race, ethnicity, age, sexual orientation, the relationship to the participant, their HIV status, and whether or not they were on HIV medications. So here is an example of what a participant's social network might look like. As I mentioned before, we would ask the participants to name 20 people or alters in the network. So the circles with the letters attached to them represent the 20 people in their social network. The lines that you see are the connections between each of the alters. So if you see the little cluster down at the bottom, you can see that there was a lot of connections between the alters as well. We were also asked to measure their social support system. So I would ask basically the frequency of contact between the participant and their alters. And I would ask the participant, how often do you see, talk to, or email with alter A in a typical month? And they would provide me with that answer. Then we would also ask the frequency of contact between each pair of alters. So I would ask the participant, how frequently would you say alter A and alter B have been in contact with each other over the past year? And once again, that being either face-to-face, over the phone, by mail, or regular mail as well too. And then lastly, we would measure the HIV stigma in the social network of the participant as well too. And I would ask the participant, have you heard any of your alters say any of these beliefs? One of these beliefs being, most people with AIDS are responsible for having their illness. Or another belief would be, a person with AIDS must have done something wrong and deserves to be punished. One quick note I would say is that these measures or these items have been used a lot in previous measure stigmas in other studies as well too. Thank you.
Okay, so now we're going to share some of the results, and I want to describe the participants who were in the study. The average age was almost 47, and the breakdown in terms of gender, about 3/4 were male, 21% female, and 5% transgender. Again, most of the participants identified as LGBT or other, but 38% I also identified as heterosexual. The majority of the participants were in a low socioeconomic status category by these different markers. And we're going to skip through that. It's in yours. We can go back to that later if we want, but we're going to just go directly to some of the findings on adherence. On average, the participants took 64% of their doses, and only 43% were taking at least 85% of their doses. So in terms of the networks, so this might, just to be clear, I was talking about the participants, and now I'm talking about the alters or the people that were in their networks, all those dots in the diagrams. So just to give you some sense of who they were, about 42% were female, 65% were heterosexual, and 19% of their members in their networks, their alters, were HIV positive. And 96% of those folks were on ART. In terms of the racial ethnic background of the alters, the vast majority were black, 83%. Some were white, Latino, and other as well. And this is a slide that gives you some sense of who the alters were, although there were other categories as well. We just didn't have enough time or room to go into all the categories. But one large category was a friend. So that was a large proportion. And also family was also a large proportion. About 9% were drug-using partners. And this was all just a reminder, this was all based on the participants' perspective. This was their self-report. So we weren't able to interview all their people in their network. Okay, so this was what they told us in the interviews about the people in their network. Now, we did find that about 1/3 of the people in their networks did make some kind of stigmatizing comment. So that was something important that we knew we needed to look at, and it did come up, as you'll see later on in our results. In terms of the members who were isolated, that means they weren't connected to other members in the network. They were like a dot all by themselves. About half of the network members were isolated or not connected to anyone except the participant who named them as someone in their network. Okay, so now we're going to move on into the describing the analysis that was conducted on the research. Just as a reminder, I wanted to also be sure we're clear that this is a preliminary analysis. I know it's in the title, but the reason why Laura added the result about finding that people's beliefs about HIV or misconceptions about HIV was significant is that we just found it this week. So we're just starting to do the analysis. So there'll be more to come, and we're going to be really happy to be able to share more of the results as well. But for now, these findings are solid, but we've only just begun the analysis. Come on over. I was in Toastmasters in college. I don't know if anyone knows that, but one of the things they drilled into my head was you never leave the podium. You never leave it empty. And that's good when you're recording too. So come all the way over, don't be shy. She's shy even of me, which it's
That's a good lesson to know for presentations. So now I'm going to talk a little bit about the analysis and what we did and some of the results. And basically we did regressions, and what we wanted to look at is what predicted antiretroviral treatment use, antiretroviral treatment adherence, as well as retention and care over the 1-year period that we were looking at participants' behaviors. So we looked at this from a perspective of different kinds of things that might be related to these behaviors, such as characteristics of their social network, as well as characteristics of them as an individual. So we wanted to see, can you look at people, can you predict their behavior by just looking at them individually, or do you have to take into account their social network as well? So I'll walk through some of these results, and basically for antiretroviral treatment use, we found several interesting results, both at the individual level for individuals' characteristics, as well as for their social networks. So first, we found that participants were less likely to be taking antiretroviral treatment if they were lower income. But we also found that their social network characteristics had an effect. So if they were in a social network with a greater percentage of other people in the network who were using drugs with them, if they were drug partners, we found that they were less likely to be taking antiretroviral treatment. And we also found that if they had more people in their network who were taking treatment, who were positive, then they were also more likely to be taking treatment. So showing that the norms in their network influence their health. And I should mention for the drug partner result, and I had alluded to this earlier, but it was regardless of their own substance use. So they might use substances a little or a lot, and that didn't matter. What really mattered was what the people in their network, how much they were using, and whether they were sharing drugs with them. So I just wanted to give an example. We've shown these social network diagrams, and as Sean and Matt have explained them a bit, the triangles are all drug partners, and as you can see here, they're actually all isolated. And what that means is they don't have links to anybody else in the network. So they're just people who the individual participant knew, but who actually they kind of kept compartmentalized from everybody else. Nobody else knew them. There were people they used drugs with, but individually. They didn't all know each other. And then the triangle you can see on the left side of the slide, that's a group of people who are all connected to each other. But what this shows is this person had a lot of drug partners who weren't connected, And this person also wasn't on antiretroviral treatment, so consistent with the results that we showed you. So the results for retention and care. And so this was defined as greater than 1 visit in the past 6 months. And I know retention and care has been defined in different ways, and we're all trying to figure out what the best way to define it is. And so that's sort of a moving target that we're still working on with the results of how to best define it. But they were less likely to be retained in care if they were in social networks with a greater percentage of drug alters. So this is very similar to the ART use results. And we also found that if they had a lower percentage of other people in their network who were on antiretroviral treatment, they were less likely to be retained in care. So showing that social networks and what people's social networks are doing around their own health behaviors can really influence the individual's health behaviors themselves. So for adherence, the results actually get a little more complicated. So I'm going to walk you all through it in the next few slides. But the first thing is that participants who said that at least one person in their network, of the 20 we asked about, if at least one person in their network said one of these stigmatizing beliefs and said prejudiced things about people with HIV, we found that participants had a lower likelihood of being adherent to treatment. So non-adherence was related to having people in your network say stigmatizing things to you. But the one really interesting thing we noticed is that there was an interaction with social support. And what that means is that stigma, if people had a really strong network and they had good social support and an interconnected network and everybody knew each other, they were more able to be resilient in the face of stigma than people who didn't. And in the next few slides, I'll explain what we mean. But basically, we define social support as people in the network who, if there were a lot of people in the network who were isolated, it meant that there was not as good a support system surrounding them, that it was a lot of isolated people and it wasn't an interconnected, strong network. But if we found that it was a strong network, and also if the participant interacted a lot with people in their network, so it wasn't just that they had a lot of people that they knew, but they really had good relationships with them, then that also protected them in terms of adherence and stigma. So here's an example of one participant when we first interviewed them at baseline and when they came in and 6 months later. So on the left is their baseline social network. What we first heard from them was their social network. And then the one on the right is the same participant, but 6 months later, showing how their social network changed. And this is an example of showing someone who has an increased proportion of people who are isolated in the network over time, which we found was detrimental to adherence over time. And so on the left side, you can see there are a few people who are isolated, but there are also people who are connected in the network. So a few people who don't know anybody else in the network. And then you can see that the proportion grows of the people who are isolated 6 months later. And that person's adherence goes down from 89 to 71%. So also walking through this slide, and this sort of describes in a visual form the relationships that I was talking about. So what we found is as the percentage of people in the network who are isolated increases, the effects of adherence are strong, the effects of stigma on non-adherence are strengthened. So if you look at the y-axis, that's the percent of pills that are taken. And so it's the percent of adherence. And on the x-axis is whether somebody heard any alter say anything stigmatizing to them. And if you look at the bars, the lines, the red line shows an increase in isolates over time. So it increased basically a weaker social network over time. And the blue bar shows that the increase in isolates was low. It was a pretty stable network over time in the blue bar. So, and what we can see is when somebody is stigmatizing in the network, if there's an increased number of people in the network who are isolated, the effect of stigma on adherence is stronger, and the person's non-adherence, adherence gets worse over time. But if we don't have this kind of network where it's changing, if we have a more stable network, the effect of stigma on non-adherence isn't really significant, so we're not finding such an effect. So what this is showing is if you have a well-connected network where people know each other and it stays stable, that's a good case scenario for being resilient in the face of stigma. And this is a very similar graph, but it shows slightly different results. And what this shows is whether the participant is interacting with people more frequently over time in their network, which is seen as good for social support and a stronger social network once again over time. So again, the y-axis shows the percentage of people who were of adherence over time, and then the percentage of doses taken over time. And the x-axis shows any alter stigma over time, whether they had alter stigma at all, anyone said any of those stigmatizing beliefs, or nobody said those stigmatizing beliefs. And if you look at the red bar, that's how the increase in alter interaction is high, which means people are interacting more and more with people in their network. They're having a stronger and stronger social network. And when that happens, we don't see an effect on non-adherence for stigma. So people are protected from the negative effects of stigma when they have this stable network. But if you look at the blue bar, see the increase in alter interaction is low. And what that means is over time, they're not increasing interaction with people in their network. Their network is actually stable, but they're not increasing. They're not getting to know more people over time. They're not having more in-depth relationships over time. And when that happens, they're less able to protect themselves from the effects of stigma. So just to summarize, and I'd be happy to talk more about these results. I know we don't have a lot of time for me to go through all of them, but the same social network factors were related to antiretroviral treatment use and care retention. And the percentage of alters who were drug partners in the network had a negative influence on people. So it suggests that there were social norms for unhealthy behaviors in the network, and this translated over to their HIV-related behaviors as well. And then the second point is that the percentage of HIV-positive alters taking ART had a positive influence, which suggests that when there are positive social norms for health behavior, we also see that influences the individual person. So also found that stigma was related to non-adherence. So when people in your network are directly saying very hurtful things related to people living with HIV, it has an effect. But what we did find is that people were more able to be resilient in the face of these negative interactions when they had a really strong social support network that got stronger over time. And so from this, we conclude that social network factors may be contributing to disparities in HIV treatment behaviors, and it's something we should look at further. And I'm going to hand it over to Matt now to have a little bit of discussion.
All right. So we were here because we wanted to share our results, but also because we would really love to get input and ideas about how to use these findings and help improve programs, and so we can all work together more effectively to address these issues. Some things that we're thinking about based on the findings are that we need community-level interventions that can promote social network support for healthy behaviors and also to reduce and address stigma. If a third of people in our participants' networks hold stigmatizing beliefs, then that could lead to mistrust and internalized stigma and a lot of issues that get in the way and become barriers at each step of the cascade of care. And so those issues really need to be addressed. We can't just think we have a pill and everything's going to be fine. We have to address stigma and the social context and the behaviors as well. And our study shows that we've got to do that with the social networks more effectively. And it also shows that when people do have strong networks, it does seem to be related to resilience and to healthier behaviors, better adherence. Since we found that the drug-using behaviors of the alters were related to some important outcomes, we think that working with the network and with the network members on substance use issues may also be helpful. And so that may be something that could be useful. I would now like to invite one of our team members from APLA to come up and talk a little bit. Come on up, Nikki. We know some of the next steps is that we want to explore social networks and address health behaviors and get your input. But we also wanted to let you know that we have kind of like a sister study as well. That's a collaboration with Harvard and Dominguez Hills and APLA. The RISE program, Project RISE, that addresses adherence with African Americans living with HIV and AIDS. And Nikki is our treatment advocate and educator at APLA. So she wanted to say a few words about the project, and then we'll get into the discussion.
Hello, everyone. I'm Nikki Rochelle. I facilitate Project RISE, which is a culturally tailored African American adherence intervention. And what I've noticed through the education sessions where we actually educate about HIV, the life cycle, the medications. We go over barriers that are preventing African Americans from adhering to their medications. And one of the big barriers is stigma. Stigma, in addition to where that comes from, the internalized stigma, lack of disclosure, lack of support. So I really feel that Project RISE, along with the other work that the team is doing, is really imperative in the community to help improve healthcare and healthcare behaviors in the community.
So if you want more information afterwards, we'll be here to talk with you, but we appreciate your comments and your work that you're doing. And we do have a few questions just as prompts for discussion that we'd like to hear about, but obviously we're open to whatever questions or input you have. We'd really like to know, how can these findings be used in programs on the ground, or in maybe developing new programs, or even new research questions. We're thinking, how can we help strengthen the connections and use the power of the social networks to support health? How might we address stigma in the social networks more effectively? And what type of research could we do that would be more helpful with these issues? So that is, we do have some acknowledgments as well. Lots of people in the community have worked on this study over time and contributed, and we appreciate all their work and help with the project.